Welcome, everybody. As we were just chatting, it's hard to believe, but it's been a year of Endoscopy Cafe expert conversations. And we made a full circle. And now, today, we have an absolute treat for you guys. Today, the topic is when things do not go as planned. Our vision was we all have challenges in our days. And I always find it the most educational is to know when people do things so much better than me, to share what is it they would have done in the situations in which I struggle. And that's the topic of today's conversation. And first of all, this one where let me introduce our idea of this meeting. It's co-sponsored by two women organizations, Association of Women Endoscopists here in the US, with my partners in crime, Dr. Krinsky and Dr. Nguyen, and I'll have them introduce themselves in just a little bit. And Dr. Nantali Paswazdi from WIGNAP. We've been honored to work with all this past year. And today we have two amazing experts to teach us. And we will start with, if I could have you guys introduce yourself, Professor Van Hoeft.
Yeah, hi to everybody. I'm Janine van Hoeft. I'm a professor at the Leiden University here in the Netherlands. I'm an intervention endoscopist, particular focus on EOS and ERCP. And besides that, I'm part of the Women in Endoscopy, and I'm also Secretary General from the UEG, which we had our big meeting last weekend. So I'm recovering. Thanks for having me.
Now you can recover either with a glass of wine or a cup of coffee or tea, whichever works. Let me, Jessica, if you could introduce yourself, please.
Hi, thank you for having me. I'm Jessica Widmer. I am at NYU on Long Island. I'm the chief of the gastroenterology division here and the program director for the Advanced Endoscopy Fellowship.
And Nantali, please, if you could introduce yourself.
Hello, everyone. I'm Nantali. I'm here in Bangkok, Thailand, and I'm the current president of the Women in GI Network Asia Pacific, known as WIGNAP. Also, the immediate past president of the Thai Association for GI Endoscopy. Currently, I'm the program director for the WGO Endoscopy Training Center in Bangkok. And I'm so happy that we have two female experts joining us today. I've been working with Janine for several years now, between WIGNAP and WIE. So great to have you and great to meet Jessica virtually today. Hopefully we'll see you in person in the near future.
Mary Lee, please. Muted.
Good morning, good evening, everyone. I'm Mary Lee Krinsky. I'm a professor of clinical medicine at the University of California, San Diego, a therapeutic endoscopist, one of the co-founders of AWE, and we've been doing this for 8 wonderful years with my co-founders. And I'm so excited to meet Jessica Widmer virtually for so many great things about you, and great to work with Janine van Hoeft again, who we just met at a WIE meeting. And Nantali, so great to see you again, and thank you for being a part of this. Really appreciate it.
Phoenix?
I'm Phoenix Nguyen. I'm a advanced endoscopist. I'm in Newport, and I'm one of the co-founders of AWE. And thank you, everyone, for being here.
All right. And last but not least, I wanted to introduce Idris Suleiman. He is an advanced interventional fellow at Harvard UCLA. And I know I'm biased, but he is outstanding. And Idris, please take it over. He's going to present our case.
Good morning, everyone. Thank you very much for the opportunity to present. So we have this morning JR, who's a 41-year-old male. He initially presented to an outside hospital in December of 2023 with abdominal pain. Was told that he had pancreatitis, but he left against medical advice because he says there was no gastroenterologist at that hospital. He went to a second outside hospital on January 3rd of this year with ongoing abdominal pain, nausea, and vomiting. At that hospital, he was diagnosed with acute pancreatitis, and it was complicated by acute kidney injury and ileus. He didn't require any renal replacement therapy, but was monitored in the ICU. He was discharged from that hospital on January 22nd of 2024. His creatinine on discharge was 2.5, and the outside records document possible alcohol-induced pancreatitis after discussions with his family. So he first presented to Harbor UCLA on February 16th, 2024. Since the discharge from the outside hospital in late January, he was having ongoing abdominal pain, nausea, and vomiting. When he came to us, he denied any medications, he denied any alcohol use, and his only past medical history was that episode of pancreatitis that he had over December and January and anxiety. He had no past surgical history. His medications were only famotidine. He has no allergies, no family history that's relevant. And socially, he lives at home with his uncle and a friend, and he is a musician for TV shows. And he denied any alcohol, recreational drugs, or tobacco. His physical exam on arrival was unremarkable. His abdomen was soft and untender. Laboratory investigations. He had an elevated alkaline phosphatase and a mildly elevated AST, but his creatinine had returned to normal, and he had a mild anemia, but was otherwise unremarkable. So this was his CT scan when he came to us in February. So, any concerns with the CT scan? And our questions to the panel is: would you proceed with endoscopic drainage? Would the approach to endoscopic drainage be any different?
So our main concern was that because it looked like there were some large vessels running through that collection, even though it appeared to be formed. Would you change anything or do anything differently, or would you do it or not?
I was actually a bit puzzled by you see a part of the collection is really nicely demarcated, but I thought a bit more down in the
Right.
abdomen, it doesn't look that much demarcated yet.
That's right. So almost like we're dealing with two different things. So, Jessica, anything we would do differently? Should we even proceed with that? With that image, look like splenic vein is compressed and running through it.
Yeah, I mean, I noticed the same thing as Janine mentioned, and I guess the question, we always ask first is what's the indication for drainage and what's the urgency for that? The biggest thing is that he's not, infected or septic or anything. The main issue, it seems, is compression on the stomach and inability to eat. So you could do a few things. You could consider nasojejunal feeds for a little while if he's not able to maintain his nutritional status. But if ultimately it needs to be drained with that vasculature in the way, you can consider drainage with an Axios, but I would put some pigtails in there to act as bumpers to kind of safeguard yourself, or consider just pigtails alone. What did you?
Can you show us a CT scan one more time? I think I've seen a disrupted wall a little bit.
Kind of caudally.
Yeah. Yeah, right there on the
Right
top.
there.
Yeah. Right
Right.
on the top, there's a little bit of disrupted wall.
Right.
Although the patient presented with acute pancreatitis back
Yeah,
last
quite a
year.
while, quite a
Right,
while
yeah.
before. You're right.
Right.
For our fellows in the group, Nantali or any of our guests, can you explain the disrupted wall and what your concerns are?
Yeah, well, my concern would be that when the cyst or when the collection is not well formed and you try to do endoscopic drainage, then you might get a leak from a non-formed fluid collection. Just like back in the day, we used to be so worried that if we drain the collection too early endoscopically, we might end up having or creating peritonitis because of the spread out of the fluid from the collection. But I've come across a couple of Japanese study saying that we could do it even when the collection is not well formed. Although and in the reality is that I wait until the collection is well formed. So in this particular case, I think most of the collection is formed, but there is that area there.
Right.
Besides from the vessel, there's that one area that I'm a little bit concerned.
Are you
And
more
this
concerned
patient,
about
yeah,
this or about the vessel? Which one you guys
both. More
which
concerned
one
about the
wins?
vessel actually. More concerned about the vessel actually, because I think that the majority of the cyst is formed. So I think that if we're going to do endoscopic drainage, then I think we still could. I would agree with Jessica that we should put a plastic stent in as a cushion just in case that the metallic stent when the cyst collapse, and we've seen some reports of metallic stent invading into the vessel, causing bleeding,
But I
like
think it's
Shyam
always
always
nice to
reported.
have
Right? Yeah.
different opinions. So I would try to buy time, still a bit of
Mm.
time, see if that collection gets encapsulated completely. Just to have
Mm.
different opinions. Then we are curious what you.
Yeah.
I
Well,
think they're gonna drain. If I were to guess, I think they're gonna drain.
well, I have no choice actually. I really didn't want to. I was concerned about the vessel and about how I had similar concerns, but the patient could not eat at all, was vomiting, and later was developing fevers too. And every our surgeons and our IR colleagues had a nice phone call with me, and I don't know how else to summarize it. As they basically told me, you have to go do it. So that was the end summary of that discussion. So we can show you what happened next. Go ahead.
So that was he came in as people usually do on a Saturday. So we planned to drain him on Monday. So this was our EGD EUS. So we can see the extrinsic compression in the stomach and the duodenum. This is the collection on EUS.
This is around the pancreatic head. Yeah, it's some ascites too. Yeah. And here we go.
So this is a post deployment of a aluminum posing metal stent. We kept him MPO and continued antibiotics. Initially, day one, he had a single fever of 38 degrees, but otherwise was having some mild abdominal discomfort. We continued antibiotics, and this was the repeat CT post lumen opposing metal stent placement.
Did you put a double pigtail in there?
Yeah, I didn't put it right up front because I wasn't sure what is happening with all the vessels and everything, and I had to do him in the endoscopy unit, so I didn't want to have a complication of active bleeding then. And it was mostly fluid. It looked to me like it wasn't a lot of solid component, but on the repeat CT, I wasn't happy with this sort of extent of drainage, so we brought him back. Uh, at that point, and there was no bleeding. And at that point, we felt that we could do a little bit of cleaning and take a look and then put a pigtail in and maybe try to get towards the head that I felt was not draining. So the compression was better.
This is the inside.
Oh, thank you, Nantali, for that picture. Yeah, and we put pigtail in. But we thought, okay, maybe things are going okay. Before we continue, I wanted to ask you guys, do you have a protocol in your institution? After you do the collection, do you get a follow-up CT scan at a particular time? How do you manage patients post placement? Janine?
Just on mute. We have a protocol, as in the Netherlands, you might be aware, we sometimes do trials. So for one of the trials, we kept a protocol, which means that it's especially a clinical, we are determining what the next step would be. So if the patient is not doing better within 3 days or even deteriorates, we go back. And we do not standardly do a CT scan. We are quite limited with the CT scans. That has also to do with costs. So we have only a certain amount of CT scans we are allowed to use per year. And so we especially look how the patient is clinically going.
Jessica, for you?
Yeah, I also let the clinical status drive the care, but the other thing that I take into account is really the composition of the collection, how much debris is in there, necrosis, and whether we're going to need additional sessions. So if the patient, and it also depends if they need to be inpatient versus outpatient, if it's a rather sicker inpatient with a significant amount of necrosis in the collection, I likely will bring them back within the first week or so after imaging to see how they're doing. If they're deteriorating, I just bring them back. If they're, very stable and they're discharged as outpatient, I may leave it as long as, I usually will scan them in about 3 weeks and try to bring them back to take out the lambs within 4 weeks usually. So it really depends on the clinical status and the composition of the collection.
Marilee?
Unmute. So similar to what Jessica was saying, if it's someone who's in the inpatient setting, then I'll let their clinical scenario contribute to the decision making, whether or not we re-image or bring them back to the endoscopy unit. If it's someone who, the more recent ones I've had, the patients are in the hospital, they do well after the drainage, then they go home, and then I do try to remove that lambs within a month, even 3 weeks. If they're doing well, I do follow-up video visits to see how they're doing. And I may actually, I still kind of, I'm still a little wary about these. I've had one migrate or embed within the tract. So I do a CT scan within I try to do 2 weeks. Sometimes the patients aren't quite so reliable, this population.
Nantali?
Yep, my practice is a bit different. That is because the reimbursement issue in Thailand. So we cannot reimburse an outpatient endoscopic procedure. So we have to admit these patients overnight just to get reimbursement as an inpatient endoscopic procedure. So all these patients get admitted after the procedure for overnight, and if they do well, they get discharged. And I would follow them clinically in 2 weeks with an ultrasound. Like Janine said, we do have some issues with the CT scan as well, but ultrasound is easier to do. So I follow them up at 2 weeks with ultrasound and clinical, and then I would bring them back in about a month's time to remove the stent.
All right. So let's see what happened next.
The day after the pigtail, he is feeling better. Was having some intermittent fevers. So we had recommended ID consultation to comment on antibiotics given ongoing fever. And then he was admitted over the next 5 days. Was continued antibiotics. Still had intermittent fevers, ongoing abdominal pain, but there was no evidence of GI bleeding. But we did notice that his hemoglobin was gradually trending downward. So we got a repeat CT angiogram, which was largely unremarkable. But looking at the trend of his labs, his hemoglobin did trend all the way down to 6.5 over the previous week. So we were notified by the primary hospitalist team about the low hemoglobin, and we were proceeding with the CTA. So our question to the panel is, with the dot turning hemoglobin, what's the next intervention?
And at this point, his vital, even though hemoglobin is stable, his vital signs remain stable. Jeannie?
I mean, if I can kick off, in those kind of patients, I'm always very, very scared that they might get a pseudoaneurysm. That's also what I try to tell my fellows, to be always aware that that might be an underlying issue. And it is often quite, subtle till it really starts to bleed, and then it really starts to bleed. So that would be in my mind. So I'm happy that you're going to do a CTA.
All right. So let's see. It really starts to bleed. Let's see what we CTA didn't show anything, so we went in endoscopically, and let's show more pictures of that. Well,
Okay.
that's easily recognizable blood. More of that. And now the axios is also completely clogged. Keep going. So at that point, I actually called my interventional radiology colleagues to see if there's anything additional they would be able to do prior to us, looking at inside the collection or anything else. What would you guys do in this situation? Anyone? Jessica?
So the patient I'm sorry, I'm a little confused. So the patient had an angiogram. They don't see any kind of pseudoaneurysm. They see no active bleeding. And that's after your endoscopy?
That was before the endoscopy.
Sure. Okay. And so then I think at that point you've got to go in, you have to, I would take out the plastic stent, I would unclog the axios and get in the collection and see what you have there.
All right. So we got just the angiogram, the formal angiogram too, because I was concerned with his stability, and that showed no active bleeding and no embolization of anything was performed. And then nobody offered anything else other than best of luck to you. And then we went back, right, Idris, to clean things up.
Yeah, so then we went back we repeated the EGD, and then we went into the limit opposing metals. This is what we saw when we got there.
And you could just show the final product, yes.
And then we went and cleaned up.
That's like intermediate version of it, yes. And it looked like there were vessels just at the edge of the collection. Yeah, we can keep on going for the interest of time. Yeah, so we left it about like this afterwards, after cleanup. And then at that point, he continued to do okay. He hasn't had any further bleeding, right, Idris, after that?
After that, there was no further bleeding. He was monitored in the hospital. He did have a rising white count, but overall clinically was having ongoing pain. But aside from the white count and the fevers, was didn't have any other complaints. Was tolerating a low residue diet.
And then over time gotten better.
Yeah, and we did offer a repeat necrosectomy, but he didn't want to go back to
at that point.
At that point, no.
Yeah. So he overall got better. We could show the follow-up scans. He got better and got discharged. And the collections gotten much smaller too. At least the one there was still that lower portion of it, but his fevers resolved and he gotten better. And then Idris, we can get to the, for the sake of time, we can get to the point when he presented with the shortness of breath now about a month later.
A month later,
And
he
now,
breath,
right.
and then he ended up having a chylus pleural effusion, but then left against medical advice. He presented electively for an EGD EUS evaluation on the 10th of April. And on this presentation, it looked like everything had become solid, had solid necrosis.
And collapse, yeah.
That had collapsed. So then we went ahead and removed the aluminum opposing metal stent at that stage. And then it recommended for him to stay overnight for monitoring. He did leave against medical advice, but then he represented approximately a month later with worsening abdominal pain, nausea, vomiting, and distension. And at that stage, it looked like the collections had largely resolved, but he developed a large ascites, which was new for him. Yeah, he previously had small volume ascites, but he had never had large volume ascites in the past.
And that ascites was chylus ascites.
It was chylus as well, and then it was chylus. So he was discharged home after the paracentesis, but then came straight back to the ER 2 days later with worsening abdominal pain. We attempted conservative measures with a low-fat diet, and he was discharged home. We did consult IR at that stage, and they also wanted conservative management initially with medium chain triglycerides and a low-fat diet. We had offered him a clinic appointment on June 6th, but he didn't come. But then he was having ongoing abdominal pain from ascites with weight loss. He was requiring a paracentesis every 2 weeks. So he was then admitted to the hospital, and IR undertook a lymphangiogram, which was unremarkable.
Well, so essentially, there was no targets
that they
could for them to intervene. So let me stop you for a second. Anything, so as of right now, the main issue is chylus ascites. And that is what's causing most problem. Anything, any suggestion what we could do about that, Jeanine?
I have to say I've heard about it. Luckily, never had this issue myself. And what I always realize, if people tell about it, this is really cumbersome, how to get a time down. Often you really, time is an issue here, and hopefully time is going to help you.
All right.
So one of the things that I just thought, again, for our learners in the audience, maybe somebody wants to talk about chylus ascites and why that happens. Can be from injury to the lymphatic vessels, right? Obstruction of the lymphatic drainage. those are some of the causes. And then the question is what to do. And I'll turn it back to Dr. Riker.
Oh, that's great.
Let me ask you before you tell us what you did, Sonia. So is this just pure chylus ascites? There's no pancreatic
No,
ascites on
it's
top of the
just pure
chylus?
chylus, yes.
Yeah.
Yeah,
Well,
there
yeah,
was
besides from what you have done, the other thing that I've used before is a combination of octreotide and diuretics on top of the medium chain triglycerides, MPOs. If it's so massive, then we keep the patient MPO and give them TPN, paracentesis, octreotide, diuretics. That's what I've done. If
Jessica,
it doesn't work, then well,
Yeah.
wish you the best.
I can say
Thanks
I've
for
never had
that.
a case. But octreotide was also what I was gonna mention.
Yeah,
Yeah.
we've done that. We've done, but the idea for all of us, we're proactive people, that we should patiently wait is just very, very difficult to manage that. So at this point, I think his after the lymphogram and it was TPN and octreotide. And I think the timing of the taps did extend a little bit, but he is still not doing well, I would say. We're still having recurrence of ascites and has a hospital admission outside with ascites. And unfortunately, on top of everything else, he is a bit of a challenging patient that not always follows and all of that. But that is pretty much. I know there is no big reveal here, but that is what we suffered with, and what just for a few minutes that we have remaining for our side, just hoping to get impact from you. Should have we done something different? Should we attempted that drainage at the time when we were draining? Jeanine? Basically, is endoscopic drainage always the right answer?
I think there you answer already yourself the question the way you're asking it. But I still think the first you should in principle look for endoscopic drainage. And if I look at this patient and these images, if I would have done any drainage, I would have done it endoscopically. What is also making this case quite complicated, as you said, that this patient is, not really the ideal patient, sticking to your suggestions, coming to the appointments. So if I would have known that on beforehand, my threshold to drain would have been higher. Because in my opinion, always if you start draining, patients have a high chance to first deteriorate. And especially with this complex patient, that made it particularly cumbersome. But other than that, I do not have other suggestions. And this is always, of course, looking back.
Jessica?
Yeah, I think that you really had to do endoscopic drainage. You have a patient who can't eat, who's having nausea and vomiting. The only other alternative would have been, potentially a PEG J, where you're feeding the jejunal limb and draining the stomach of any contents to try to keep him I guess symptomatically controlled, but that's just really going to prolong your process and hospitalization. And then in this challenging patient, I don't think that would have been the right direction to go.
Nantali?
I agree with Janine and Jessica. I would have gone with endoscopic drainage, and I think you did pretty much what we would have done. This patient is high risk. I think one thing we can learn from this is that we should be very cautious when we do endoscopic procedure, especially in the presence of large vessels and not well formed collection. But we still, if we were to do this again, and if we had to drain this patient, we would have gone with endoscopic drainage, right? Because percutaneous drainage will increase risk of fistula And surgery, the surgeons, they, right now surgery is not the first line anyway. So yeah.
Mary Lee, Phoenix, parting comments?
Yeah, Nantali, at the time of EUS, given that area of disruption, would you have gone more distal? Would your approach have been different to find an area that's a little bit still foreign wall, but a little bit more closer to the area that was disrupted?
No, no, and
That's a
and I
great
think
point.
I would probably I would I look at the endoscopic the EUS image when Sonia did it, I thought I would have gone at the same, location. I don't know if it would make any difference.
Phoenix, you would have done somewhere where, right? Is that what you're suggesting, that we should have gone something where it was more?
It's
No,
always
no,
easy to go backwards and see,
no.
retrospectively. But is there something at the time of EUS that you would have aborted, Nantali? Like a huge arterial vessel? What would
Yeah,
make you?
if you see a pseudoaneurysm or intervening vessel, then yes, I would have aborted it. Once I aborted a case with varices, like a lot of varices in between, I have aborted that because I couldn't find a window. But in this case, I think you see the window very nicely. And I would think that if we were to go through that area where the wall was disrupted, we would have a different problem. Like when you deploy the stent, you won't have any wall for the stent to snug in. Maybe the stent deployment might have been a little bit more of a challenge. I that would be my guess. Yeah.
Mary Lee and Janine and Jessica, do you guys ever consider embolization ahead of time? Someone who is you expect to be high risk for bleeding?
When you
We
have that,
some
go ahead.
we do it sometimes if we do see already a pseudoaneurysm, then we consider to embolize that before we go for drainage.
Jessica.
But I don't think that we would have done it preemptively here without the pseudoaneurysm. And you had your multidisciplinary discussion prior to drainage. So, you had crossed all the T's and dotted all the I's.
Mary Lee, what do you consider embolization in something like that or no?
I'm aware that people do it and it's discussed. I haven't been in that situation, fortunately, but definitely something that I would consider. But I think in this case, it looked like you had a great window. You had some bleeding. There was no consequence. I've never seen a case of this chylous ascites. I find that kind of fascinating. You didn't comment whether your lymphangiogram found the source
Yeah,
of the
they
leak.
they did an extensive lymph. English doesn't come easy at 5 a.m. Yeah, they didn't find any targets, anything. They went everywhere on every level and they couldn't find a target. It just disrupted the entire thing. So they basically said, best of luck to you on that. Similar to what Jinian said, let's hope for the time to work. Yes, but
it's
yeah, go ahead,
interesting
please.
because right now I was on service last night. We have a patient similar, a young man. I don't know how reliable he'll be. He's in our hospital with acute pancreatitis and a large collection that's not well formed. And there's discussion and he's having fevers. But other than that, I think he's doing okay. He has been on pressors off and on. And the question is, do we drain it? Does IR drain it? So anyhow, food for thought.
Here we go, food for thought. And I want to make sure we get to Nantali's case. Thank you so much. Thank you, Idris, for an outstanding presentation.
Yeah, thank you.
All right.
Great job.
So next, I'm going to introduce our fellow. So I have with me today Natapat, who is our current advanced endoscopy fellow. And he is kind enough to present us another interesting case, although not as challenging as the first case, but this is more related to technical issue. Okay, go ahead, please, Natapat.
Thank you, Dr. Nantali. Uh, Here is our case today. 71 years old man with multiple medical problems. He was presented with gastric outlet obstruction due to non-healing peptic ulcer at the pre-pelvic area. Multiple biopsy of stricture were negative for malignancies, and CT scan showed no evidence of malignancy. And he was treated with endoscopic balloon dilation multiple times and fell. So currently, he has replaced the NG tail feeding for 3 months as he fails the surgery. So impression was benign gastric outlet obstruction with failed endoscopic treatment. After we discussed the treatment plan with patient, we decide to perform EUS guided gastrointestinostomy. Equipment preparation of EUS guided GE. We used linear echo endoscopy, and we used lamp with cautery tips, water with methylene blue, and we used occlusion balloon and guide wire, but were used optional. So in SVR hospital, we used a DIY single balloon catheter with hot exhaust system. As shown as video, we adapt the 26 millimeter aortic balloons using in cardiothoracic unit stick with NG-TIL 10 friend, and we use fluid as methylene blue plus sterile water. This video show after we put the guide wire inside the jejunum, and we insert the DIY single balloon and into the jejunum, and it fills the water via NG-TIL. And after that, we see the small bowel fill with fluid. And then we start to perform EUS guided GE. First, we puncture resistant small bowel with hot exhaust system. And we start to deploy the first flank and pull back to get closer to the wall and switch and switch to the endoscopic valve. Pull back and then deploy the second flank. This is normally we do, and you see the methylene blue plus fluid come outside the stent. But in our case, that was different. And first we examination of the stomach, and you see the NJT was placed. Then we use the single balloon DIY to exchange the NGTs. We flush the fluid to fulfill distance small bowel, and in the fluoroscopic we will show distance small bowel, and this EUS will show distance small bowel in the EUS will. And then after we look for the good position, we start to puncture, and then we try to insert guide wire first. This video show insert guide wire, and then we lost. Then now we lost visualization a little bit, and we decide to deploy the first flank. And then we pull back, stand closer to the wall, and then deploy the second flank. But you can see there is no fluid come outside the stand, no blue fluid like this normal. And then we pull resheet, and you can see the white through the lamps. And then when we look closer to the stent, you see this one. This picture showed the yellowish like fat inside the luminal stent. The stent was misdeployed. What would you do next?
So yeah, I think this case, I think some of us might have experienced it or might have heard about it, but this is one of the, I believe this might have been our first case doing EUS GJ. And at this point, I want to invite, maybe we can start with Janine, and then Jessica. I just saw Janine do one of these procedures during the EUS guideline, I think just a couple of weeks ago. Yeah, so the question is, you know, when you see something like this, what would be your approach? That's number one. Number two, I like you guys to comment on the use of wire, because I think what might have been my problem was that I used the wire, and the wire kind of pushed away that loop of distended small bowel and kind of lost the visualization a little bit. But I thought, oh, the wire is there, and I saw the bowel earlier, so it might be okay to just deploy, which is bad decision. So Janine, what would you do at this point?
Yeah, so just taking it from this point where we see this abdominal fat, then I would say, okay, luckily you do have a wire in place, because then you can see if you can still, reconnect if this wire is deep enough and still in the duodenum, so you could place another fully covered stent.
Mm.
So that would be an option for me. And if you think this wire is in between, so is not in the duodenum anymore, then you could take out everything and just clip it. I mean, I think you're there early. It looks all quite clean, so I wouldn't be too worried.
What about you, Jessica?
We've all been there, and this is a humbling one.
Oh, I'm glad you said that,
Oh
Jessica.
yeah. Yeah, I mean, there's been a lot of evolution of the techniques for this procedure. We've learned hard lessons. I don't use a wire. I do preload the Axios with a guide wire so that if I have any concern, I can quickly pass a wire. But I do find, and you said one of your first ones, our early experience is the wire usually pushes tension against the back wall of the small bowel and will push it away, and you lose your visualization and can misdeploy the stent. So I don't do that. So in this situation, there are a couple things that you can do. As Janine said, it's pretty inconsequential. You can simply remove the stent and clip it closed and decide on an alternative treatment, whether that, for your patient, it's a benign indication. And so, would you use, a fully covered metal stent to kind of bridge that area, maybe need to secure it in place to reduce the risk of migration. The other thing you can do that's been described, and again, I think my decision making would be really driven by the patient. As Janine said, if your guide wire is still in place in the duodenum and you're confident about that, you can simply bridge it, whether you think you can bridge it with another Axios or whether you want to use a fully covered metal stent. Like I usually use a 20 millimeter esophageal stent. What you can do, and I'm not sure if I would do it in this patient or not, but one thing you can do is, dilate your Axios. You can use you need a double channel therapeutic scope. You advance that into the peritoneum and see if you can see that loop of bowel. If you can easily identify it, you grasp it, with a raptor or something like that, to pull it close to you. Use a needle knife to do enterostomy and then advance your guide wire through there. And then, you're simply placing your stent of choice, whether that's a bridging Axios or a longer esophageal stent to bridge. If you do use the longer esophageal stent, I do suture those into place into the stomach. Not something I do routinely. I've done it one time, but it was in a patient with malignancy who had, kind of a fair life expectancy. This drives the decision making, I think, when you're talking about how should we treat gastric outlet obstruction. I think because of our experience with this procedure and some of the shortcomings of it, if a patient doesn't have a long life expectancy, maybe it's best to just kind of put an enteral stent in. We love this technique because we know the patients do so well with it clinically, so that sometimes drives the decision. But I've been talking for a long time. Those are my thoughts.
Oh, that was good. I've actually never tried to do that technique, or I don't hear a lot of people talking about doing that technique. So that's eyes opening, actually, Jimmy. And
Nantali,
maybe, yeah.
that modified balloon, that is very interesting. What is it that you use? So what is the aortic balloon, or what is it that you
It's
modify?
Yeah, it is an aortic balloon that vascular surgeons use for the aortic valve work. And because we couldn't get double balloon from Takao Itoei, it's not available in Thailand.
Yeah.
And we tried to do the freehand technique before when we started, and we felt that it was kind of difficult to distend the small bowel. And when we first started, we didn't have much of experience. So we kind of modified this, and we tried to use the nasal biliary tube, tried to use a nasal jejunal tube, couldn't really hold the fluid well. So we came up with this single balloon, and initially it was suggested by one of the surgeons, a colleague of ours, that we can try
What
to use this
size do
balloon.
you use it?
Well, the size of the balloon is 3 centimeters,
Okay.
so it will help hold the fluid quite well.
Hmm.
Right, and we just attach an NG tube to that aortic balloon just to instill the water.
Oh, wow.
Right, so I think it works
Janine,
quite well.
Jessica, what do you use to expand the small bowel? Because I find that part sometimes very challenging, with the nasopiliary drain falls back into the stomach. I had a recent one that we were struggling a lot to keep it in place. And any tricks for that?
Yeah, what we
Okay.
normally do, as you can see on our recent one we demonstrated live, is that we do use a feeding tube, and we use then the rapid refill system. So with that you can instill water, as said, really rapidly, and I think also in huge quantity, which in my opinion really gives nice distension of the bowel. And we give glucagon or other antispasmolytics.
Jessica, what do you
How much
use?
fluid did you use, Janine? Like 500 or a liter? Like how
Yeah,
much
I
fluid?
think easily we use a liter. It as you have seen on the video, it's expanding so quickly, and you can also keep it by just asking the nurse to more or less continuously pump in the water. That's what they can do with this rapid refill system.
Okay.
Jessica, what do you use?
I use a nasobiliary drain, and yes, sometimes this is the most annoying part of the procedure.
Yes, I just had that.
Yeah, lessons learned. I think it's important to do nasopharyngeal exchange. I think that when you just, have the tube coming out of the mouth, I've just felt that it gets caught up in my scope, my EUS scope, as I'm going in and out, even small motions. So I think doing the oropharyngeal exchange really does make a difference. So I use that. The other advice I would say is I do not fill the bowel with fluid until I get the EUS scope in place. I do use a lot of fluid, 500 cc's to a liter, but I'm cautious not to do that until I'm kind of in place and ready to go. The reason for that is, you just get so much evolving experience as you do these. And, I had a woman who her motility was so fast, within minutes the colon was filled. And I'm a little crazy with this procedure. I'm very cautious. So much can go wrong. And I double and triple check myself. So what I actually do is I do a practice run with a 19 gauge needle before I puncture. And I find this useful for multiple reasons. The first thing is sometimes the tangent that, same as when you're puncturing, an uncinate lesion or something during USFNB, the tangent that your needle comes out is not really where you expected it to be. So this is a practice run for me to make sure that I love the angle that I'm going at with the Axios catheter. I aspirate fluid. And as I mentioned, one time within minutes, I aspirated fluid with methylene blue from the colon. So you can be really surprised. I do use glucagon also. And then I keep that in place and I hook our water pump up to the needle, and that's when I really pump a bunch of water in I use normal saline with some methylene blue and a little bit of contrast. That's when I have the team start setting up the Axios, and I leave that needle in place. It keeps my loop of bow in place until I'm ready to do just a really rapid exchange for the Axios catheter, and then I do a direct puncture that way.
Oh, so you fix the bow with
Do.
your 90 gauge needle.
Yeah,
Ah.
and I'm not using a wire at all. It's just the needle. It allows me to aspirate. I inject some contrast, make sure I love my position. I love the angle. I'm giving more fluid. I'm setting myself up for success. So it's a little bit of a added step, but I find it very helpful.
Jessica, how did you know you were in the colon that time?
The contrast injection. And I think you have to be a little bit careful. I've just found that as I don't know, I usually find a nice location around 50-ish centimeters from the incisors. If you start pulling back a little bit, you can get colon. So I'm pretty cautious about that.
Let's see. Okay, so maybe we can share with you, Nat. Can you share with them what we did and what happened to the patient?
We decide to remove stent by to forceps, and then we apply the hemoclip to close the gastric puncture site, and this is end of our procedure at first time. So
Right. So before you go ahead, Nat, I just wanna say that we decided to remove the wire because we were not sure if we were completely outside the small bowel. So we didn't even try to put a second stent in. And not to mention that that was my first procedure. So I a bit freaked out that I saw the fat. So I just wanted to kind of make sure that the patient's stable, and then we close it for today. I even tried to look into the small bowel to see if I could see the introtomy site. So maybe I can close that site as well. But I couldn't really see. I couldn't really see the puncture site from the small bowel side. So I just say, okay, let's just close the gastric side, put it in J, and then keep the patient in PO and see what happens. Continue antibiotics. Okay, not sorry to interrupt. You can go ahead.
okay, thanks, Dr. Natalie. As Dr. Natalie say, we just NPO, IV fluid, and place NJ tube. Give the antibiotics, and we done the plain abdominal film that show no free air visualization. The patient looked well, no pain and no fever, and was discharged after 3 days of observation. So we decide to underwent the second attempt at 6 weeks later. We use same equipment, single balloon catheter DIY, and we used hot Axios system. This time we didn't use the guide wire. So we puncture at the good position and good visualization. And after we deploy the first flank here, we pull back the stent and make it closer to the wall. And then we switch to the endoscopic wheel and deploy the second flank. And this time, as you see, you can see the fluid, yellow fluid into the stent. And the water and bile came out, and procedure was done successfully.
Bravo.
And this is the fluoroscopic imaging, confirm that contrast passed through lamps into the jejunum. So the patient able to start liquid diet following day, and lamp was placed at follow-up EGD. Patient look well, clinically well at 6 months of follow-up. So as our case, we report the pitfall in stent deployment during US guided GJ using hot Axios. We suggest we maybe 3 pitfalls that we found. One is mispuncture. The tip of the lamp is outside the small bowel, but first flank is not yet deployed. It may caused by inadequate distension of target small bowel with water. The possible rescue maneuver was retracted back and reattempt to get when we getting a better visualization. Second was the first flag is deployed outside the small bowel. It may caused by puncture outside target small bowel or stent slip during deployment. So the rescue maneuver is if the stent was in position, we can retreat back to the deployment and we can deliver the system back and close the puncture site, and maybe we need to attempt in the same session. Last but not least is the pitfall of second flag is deployed outside of stomach. I think it is the most difficult pitfall. It may cause by deploy the stent outside the working channel or too far from the scope. If wide cannulation through puncture site into the deployed stent is occurred, we need to place the new stent, and is for sure is a conversion to surgery is also an option. So recently, classification of misdeployment during US guided TTA was published in GIE. So they proposed four classification of misdeployment stent. One is deployment in peritoneum. Two, misdeployment with enterotomy in jejunum. Type 3 misdeployment of proximal fan. And type 4, stent was deployed in colon, so we call gastrocolic deployment. I think this case is maybe type 2 in deployment in enteroscopy. Thank you for attention.
That was great. Thank you. Thank you so much. Before we adjourn, from our experts and from AWE and Vignav, if you guys for this gastrojejunostomy replacement, just one pearl from each one of you, what should we be aware? Or what should we learn? I'll start with Janine for the gastrojejunostomy.
What I highly appreciate is that after the failure, you went back again. And I think that's one of the things we should keep in mind. I mean, failures happen to us all, but you have been really brave to go back. And I think also that's a learning point for us. There is a second attempt, and that is often successful.
Jessica?
Yeah, there are so many things with this and so many pearls. And I agree with what Janine said. And I think, as you attempt these, you just have to know the potential complications that can come along the way and have in your mind how you're going to fix it. And I think the only one other thing that I'd mention that we didn't mention so far with this is the question of after the stent is placed successfully, should we be dilating? And I think, there's great variability on this through the world. And I think there is just not enough value to do so. I think there's been concern for stent migration as a result, bleeding or stent migration. So that's the one other thing that I'd mention is I don't think it's worth dilation of the Axios stent afterwards.
Nantali, what one lesson to all of us?
Yeah, what I've learned from this case is that when you do a therapeutic EUS, be very careful when you lose your visualization. I think this case created a problem because I lost my visualization and I continue to deploy that first flange, which was a bad decision. So make sure that you know where you're going. If you lose your visualization, maybe you can come back and get your visualization again before you proceed. Yeah.
Phoenix, anything to add?
No, I thank you, everyone, for being here today. Such a wonderful experience.
Mary Lee, to finish it off?
Yeah, I mean, one issue is, that I always think back on Billie Jean King saying, failure to prepare to fail. So I think rehearsing before, one of you said you rehearsed before. I think that's an excellent plan. but I'm coming from the perspective of I've done, I think only 4 gastroenterostomies on my own. 3 with a representative there for support, and 1 on my own last week. So I'm in the early phases of doing this procedure. So again, be prepared. And so this was an excellent discussion. I appreciate everyone participating, our guests, Jessica and Janine, thank you so much for being here today.
I'm gonna second that, and the recording of this is gonna be available on the AWE side. And Nantapod and Idris, I'll be bugging you in a little bit for write up of the cases. So we put out a little write up with the summary of the teaching points for everyone. So thank you so much, everyone, and I hope you have a good day and good evening. And thank you again.